Hello, my name is Kat Feller, and today we'll be covering Chapter 11, Sleep, Elimination, and Noncompliance in Children. Objectives. By the end of this presentation, viewers will be able to identify variables that contribute to sleep and elimination problems and noncompliance. Also, by the end of this video, viewers will be able to identify the relevant behavioral and behavior analytic literature related to assessment and intervention for these behaviors. BCBA task lists. I chose H3 recommended intervention goals and strategies based on such factors as client preferences, supporting environments, risk constraints, and social validity. After watching this presentation, participants should take the quiz posted not only here but also in the George Mason website. You'll just go through, and for each question, it'll be 1 point each. There are a total of 5 questions, so you have to earn, or you get the opportunity to earn 5 points. And here's an example of your participation rubric. At the end of the quiz, you will be given immediate feedback on which questions were correct, and if you missed any, which ones were incorrect. Sleep. Between 25% and 35% of typically developing children and up to 80% of children with developmental disabilities experience some form of sleep disturbance. Sleep disturbance symptoms may include inattention, irritability, hyperactivity, impulsivity, academic underachievement, mood disorders, increase in aggression, and increase in self-injurious behavior. These symptoms often look like other disorders such as ADHD and autism. Therefore, doctors often diagnose without implementing sleep interventions first. Owens Physician Report. Owens asked physicians to report on the importance of sleep. Of the participating physicians, only about half regularly conducted sleep disturbance assessments on patients other than toddlers. Additionally, more than 90% of physicians reported the academic impact of a sleep disturbance to be important or very important. Furthermore, many physicians reported a lack of confidence in screening and tracking sleep disturbances in older children. Another study conducted by Metzel, Courtney, Crissett, Ramos, and Mendel found that sleep disorders were underdiagnosed in school-aged children and adolescents. In the Gerber study, teachers used the Connors Global Index Teachers score to score the behavior of students in the school setting. In the study, participants ages were 7 to 11 years old were randomly selected, assigned to adding an hour to their sleep schedule or reducing their sleep schedule by an hour. The CGIT scores indicated a significant improvement in emotional and behavior performances in the individuals who added an hour of sleep each night. The opposite effects were reported for those who reduced their sleep by 1 hour. Sleep assessments. There are 2 main screeners that can be used that were suggested within this chapter. The first is BEARS, which stands for bedtime problems, excessive daytime sleepiness, awakening during the night, regularity and duration of sleep, and snoring. The other one is sleep log, and this would be observational data used to hone in on the areas of concern that were noticed from the BEARS screener. Sleep disturbance treatment. Bedtime problems. Treatments that were suggested in the book were to establish a bedtime routine, restrict afternoon naps, caffeinated beverages, sugar, and electronics. Bedtime fading procedures, such as delaying bedtime, or based on the average time the child tends to sleep naturally. Behavior insomnia, sleep onset association type. The environment provides automatic reinforcement for behaviors incompatible with sleep. Next steps would include stimulus control with behavior training, such as bath time and reading books. Another treatment suggestion was the excuse me, I need to, which the parent sets up outside contingencies in which the parent needs to leave the bedroom or the child in order to give the child some opportunities to independently go to sleep. Behavioral insomnia, parent limit setting type, which is common in older children. They're capable of falling asleep independently, but engage in other non-sleep behaviors to gain reinforcement. Another treatment method would be the bedtime pass, which is an exchange for a quick trip out of the bedroom to gain tangible reinforcement, or to gain tangible reinforcement in the morning. So the child might cash it in for a bedtime hug, or to go get a drink of water, or the next morning the child can obtain an actual favorite toy or something. Sleep disturbance treatment. Excessive daytime sleepiness. Naps past preschool years are a concern, as well as falling asleep in locations other than the bed. These symptoms, the following symptoms may also be present: irritability, sluggishness, hyperactivity, and forgetfulness. Sleep disturbance treatment. Awakening during the night. This may look like difficulty falling back asleep or awake for extended periods of time. It requires the caregiver's presence to fall back asleep. Treatments would include independent sleep onset, no rocking or singing the child to sleep, and reinforce falling asleep only in the bed. Sleep disturbance treatment. Regularity and duration of sleep. Pay attention to light signals, meaning how much light is let into the bedroom or at what time lights are turned on and off around the sleeping areas, regular bedtime and awake time routines, and outside stressors. Treatments may look at a 15-minute delay in bedtime, or, if that doesn't work, taking the child out of bed and only letting them return after 1 hour. An additional thing to consider would be to identify possible stressors. Are they avoiding aversive environments with their sleep tendencies? For example, maybe they stay up late so that they are sleeping in the morning and they miss the bus to go to school because school is a primary stressor, or something happening at school is a primary stressor. Snoring. Psychological concerns. Sleep apnea can offer a series of health risks, and this would need medical attention and evaluation. Things to look for: morning headaches or vomiting, loss of muscles, hallucinations, frequent repetitive leg motions. Elimination. There are two major problems associated with elimination. The first one is enuresis, which would be the urine release frequently and uncontrollably throughout the night, or encropresis, which is the feces release throughout the night. Enchirisis affects 5 to 10% of 5-year-old children, and encropresis affects about 1% of 5-year-old children. Please bear with me with my pronunciations. Other problems to consider would be constipation and urinary tract infections. Elimination. In order to master elimination, the following two goals must be met. The child must be able to identify bathroom sensations, recognizing that they need to pee or to poop, and there is a need for and mastering of chaining. Elimination. Common treatments. The first common treatment would be graduated guidance. This would be chaining, such as first the child must undress, void, dress, flush, and wash hands. Prompting hierarchy is also involved. This starts with a verbal prompt, goes to gesture, model, and then a physical prompt. Reinforcement-based treatments. Our preferred stimulus immediately following elimination. Scheduled toilet sits and elimination schedules. Setting a child on the toilet for a set period of time. Then tracking how often and when the child eliminates. Then adapting this particular schedule to fit around the times the child tends to use the restroom or has to go to the bathroom or eliminate. Avoid use of pull-ups or moisture-wicking materials, as this may not sense an uncomfortable or aversive environment for the child, and the child may simply continue. Hydration. Increase access to fluids to increase the chances for elimination. Punishment. Remove stimulus following a response. Decrease of future frequencies. Verbal reprimands. no more wet pants, or restoration, cleaning themselves and putting the environment back together. Urine alarm. This would be a device that detects the wetness and produces a sound. There are variants of this particular device that may range from a louder sound, and some have the capacity or capabilities of producing a lower sound so you can make the stimulus less aversive throughout the day or throughout the schedule. Manipulation of stimulus control. Manipulate SD of an inappropriate elimination routine and transfer it to an appropriate one. Noncompliance. Assessing noncompliance. Measure listener repertoire and their language skills, and the ability to follow demands, or the motivational setbacks. These two are the most important things for assessing for noncompliance. It's important to understand if this is a language based problem or more of a motivational setback. Additional things to look for would be set conditions, positive reinforcement, access to preferred stimulus, or a negative reinforcement, such as, is this providing escape, avoidance, or non-preferred stimulus? Antecedent and consequence-based interventions. These include adding or removing stimuluses, such as vocal prompting, and may also include vocal prompting, modeling, and physical guiding. This section would be what questions or wonderings do you have? And here are my resources for you guys to use. So again, if you go back to, in this case, it's slide 4, or for you guys, it will be linked into the George Mason website. You're more than welcome to go ahead and click on the link. It will take you to the quiz, which you'll be sure to make sure you put your full name in here so that you get credit, and then answer the questions as you see fit. Each one has a red asterisk next to it. That's just to remind you that you need to complete this in order to get credit. And then if we go back to our slides, the participation rubric, which you see here, is also set up into a Google Doc for you, and it has all the directions here. So viewers will complete the quiz related to the presentation content. Each response is worth 1 point. I hope you enjoyed this short presentation today, and if you have any questions, please let me know. Thanks. Bye.